Good morning, ladies and gentlemen. After commonality, probably CSR is a fairly common disease, but if you see in the absolute numbers of the entire group of patients, I think choroidal neovascularization may end up becoming more common. And not only common, but also blinding. The most important thing is that this is a blinding disease, and proper management can today help to save many of these eyes. We all know that choroidal neovascularization is basically, these are abnormal new vessels growing from the choroid under the RP and breaking through, reaching the subretinal space. The disease can be because of ARMD, the most important for us. High myopia could be inflammatory and can also be idiopathic. The main problem is that this causes fluid under the retina and into the retina, and in addition to that, it finally bleeds, finally resulting in an irreparable loss of vision. What are the symptoms that will give you an idea of what you're dealing with? The most important are scotoma, blurring of vision, and metamorphopsia. Blurring is actually a non-specific symptom. So, and in fact, actually misleads the patient, especially if it's an old patient, says blurring must be cataract. So he actually misses out on the, but the scotoma is definitely something that should raise your suspicion, especially when the patient says, wherever I move my eye, the scota moves exactly that much. Unlike a floater where it will move past and then move back. So a scotoma is, if it's a floater, it's moving independently of the eye movement, whereas if it's because of a CNV, it's moving exactly with the eye movement. So this is what you see. This is how a patient sees a scotoma. Now, the other important thing is metamorphopsia or distortion. So what the patient will say is that when he sees lines, instead of looking straight, if he looks at a window, the edge looks as if it's stayed out. It's not straight. Now this is again a very important sign or a symptom of a CNV. Importantly, CNV doesn't affect the peripheral vision as a rule. So the patient doesn't go blind in that sense. His ability to read gets affected, his ability to navigate gets affected, but not completely. His peripheral vision still remains. The most problematic thing is that he can't read. CNVs could be classic, occult, or minimally classic. A classic CNV is on fluorescein angiography. You can see what is there is early hyperfluorescence, and this is a hemorrhage. You can see this is the patient. And the hyperfluorescence becomes more intense in the late phase. So it's a very classic picture. You may even see the network of vessels in this early phase. When it comes to occult, there are different types of occult CNV. This is a common one where you see early phase, there's hardly any leakage. The late phase, you see a late leakage from an unknown source. The second is a fibrovascular PED, where you have this stippling starting in the mid phase, continues further in the late phase, but the margins are reasonably well defined. And finally, a serous RPE detachment, where you have hyperfluorescence starting in the early phase, becoming more intense, but the margins are well defined. So you know this is what you're dealing with. Of course, OCT makes this very simple to diagnose. What is the natural course? Supposing I leave this CNV alone, if I don't treat a patient with an exudative ARMD, what would happen to him? Well, what the results show is that in 2 years' time, you expect 50% of the patients to have lost more than 6 lines. So it's a huge loss of vision over this period. How do you approach a patient? Well, the first thing is if you see a patient who looks like a dry ARMD also, it's worthwhile doing an OCT to pick up an early CNV. Patient may sometimes miss it, and you can pick it on time and treat it early. Once you found a lesion which shows some fluid, do an FA for complete categorization. The subtype you will be able to make from that, and then you decide how you want to manage it. Of course, another important thing when you do the fluorescein angiography is what is the location? Is it extrafoveal or subfoveal? A lesion like this is easily amenable to laser. And even today, the most definitive treatment you have for a CNV is laser. Unfortunately, not something you can do for a subfoveal lesion, where you'll destroy the lesion, but you'll also destroy the vision. As far as the management is concerned, even today, well, it's basically anti-VEGF agents, and the gold standard even today is Lucentis. However, that does not mean that a patient who can't afford Lucentis should not be treated. Avastin is a fair alternative. It works and works fairly well. Aflibercept is useful in non-responders, and we are just getting early reports yet. As far as the VIEW study was concerned, it was as good, but the point is there are anecdotal reports that maybe in occult CNV, it may work where you're not getting a response from Lucentis. In all cases, the treatment is indicated for 3 loading doses. In all patients who have an active lesion, mind you, an active lesion on fluorescein angiography and OCT, and I would try that even with any degree of visual acuity. What do you do after you've done that? After you've done that, you've given the first 2 doses, you had a lesion, you assess the response, now you get a dry lesion. The patient's responded. Now, this is the patient where I would actually put this patient on a PRN follow-up, a PRN treatment with a follow-up on a monthly basis. That means you monitor this patient on a monthly basis. If I don't get any recurrence in the next 3 months, I will increase the duration between his follow-ups to initially 6 weeks and then 8 weeks till I come to a quarterly follow-ups. I will not treat this patient on a treat and extend basis. On the other hand, if a recurrence occurs, this patient requires a PRN treatment. Again, he needs a treatment, and then again the follow-ups will begin monthly. And then once it stabilizes, you can again go back to 3 monthly follow-ups. What happens if the lesion doesn't respond? Say it becomes stable, it's not increasing, it's not decreasing after the first 3 injections. Now what do? You continue the monthly injections till the lesion becomes dry. If it becomes dry, you can go back to the paradigm which we talked about before. What happens if it doesn't become dry? Of course, I think Dr. Sanjay Chaudhary will be telling us about how to reduce the burden of treatments, and that would be a more detailed lecture. But basically, if you reach a stable level, I think this is a situation where you could consider a trial of aflibercept. But if you're not getting that, if you're not getting an improvement, this is the kind of patient whom I would like to put on a treat and extend regime, where you slowly increase the duration of intervals between the treatment. If the patient stays stable with that, you can increase the duration between the injections from 4 to 6 weeks, 8 weeks, until you come to quarterly injections. But if at any point of time the patient deteriorates, if you find that you gave 6 weeks, he deteriorated, go back to 4 weeks till you reach a stable state. Of course, there is another group of patients who do not respond. You gave the 3 injections, the vision is still decreasing. I think this is a situation where a shift to aflibercept is probably warranted and may help some of these patients. It's easy to say when to treat. What is more important is when not to treat. And holding your hand, knowing when to hold your hand is probably more important than just giving the injections. So if you have a serous RP detachment without a vision loss and it's non-progressive, this patient does not need a treatment. Incidentally, if you go through any study on any of the trials, all the studies when they talk about occult CNV are talking of progressive occult CNVs. They're not talking of a stationary lesion. So if you look at the fine print, you find in every one of them the statement progressive is part of the treatment, is the part of the decision to treat. In a macular scar with worsening to a point that the vision is less than 360, and if it's the versi, I think it again doesn't need a treatment. So a patient like this doesn't make sense to treat. A patient like this, now if this was a fresh hemorrhage, you could consider, but what if this is an old hemorrhage, this is the versi, this is a situation where it doesn't make sense to treat any further, especially when the patient is paying for this. The last group of patients is patients with a PED. Now, if you have a patient like this PED could rupture even after. It could rip after an anti-VEGF agent. If the macula is okay, he's 6'6". Don't touch till he starts deteriorating. If he develops subretinal fluid, I would consider that an indication for treatment. But if it is stable, we would leave this alone. Incidentally, this patient during follow-up did deteriorate, but was treated with anti-VEGF agents. He ripped, but still managed to maintain vision because the macula, the fovea, was spared. The question is, you've treated these patients. You've given 1, 2, 3, 4, 12, 24 injections. What's going to happen in the long run? If you have a patient who's 65, he can expect to live till 75. What's going to happen in this time? Well, in a short run, 10-letter improvement could be looked at. 30% of the patients could get more than this. But if you see what happens in the long term, you see initially they improve. When you follow these patients up, this was part of what was called the 7-Up trial, where the patients from the first study were followed up in the Horizon and then followed up in this trial. But then slowly they begin to deteriorate. As a group, if you take them, they start deteriorating. However, if you see individually what's happening, a quarter of the patients will, if they maintain their regular follow-ups, get greater than 20/40 vision, and which is great. 1/3 of the patients can expect 6/18 vision or better. But the sad part is that a third of the patients will actually have a more than 3-line loss over this period. And the important thing to remember is that an active exudative lesion on OCT will remain in more than 50% of patients, and they would be receiving treatment. So please, when you counsel a patient with CNV, tell him this is going to be, or there's a possibility that this may be a long-term or almost a lifelong treatment. The lessons we learn from all these studies is that it's important to monitor your patients. If you monitor your patients monthly till the lesion heals, and then lifelong, at least 3 monthly, and if you have a high index of treatment, suspicion for retreatment. Now, what is that high index of suspicion? A loss of 5 letters is an indication. A BCVA, an OCT evidence of new macular fluid or a persistent fluid following the last injection is another indication for treatment. An increase in the central retinal thickness by 100 micron is an indication for treatment. Any new hemorrhage is an indication for treatment. But most importantly, the treating doctor has been given the right to treat a patient if he feels that there's a subjective indication of increase in macular fluid, because he's the one who's been following up this patient most closely. If you do this kind of intensive follow-up, this kind of intensive treatment whenever required, the chances are that a lot of your patients will manage to get and save vision. Ladies and gentlemen, eternal vigil is the price we pay for maintaining vision in patients with CNV. Thank you very much.